The first talk is going to be AKI in the Neurocritical Care Unit. Zachariah Ricci will be giving it for us. Welcome.
Good morning. Okay, thanks. Thank you for the invitation, and thank you for the topic, which is something that we don't talk much generally, especially in our critical care nephrology meetings. What I found in my research for preparing this speech was that we can definitely talk about kidney brain, or better, in Latin words, nephroencephalic syndrome and an encephalorenal syndrome. So the axis between this and the crosstalk between these two organs does exist, and as we will see, is very important. I will talk a little bit about the chloride load in acute brain dysfunction, which is something essential in management of brain dysfunctions, and the importance of KRT modality and timing in these patients. Okay, we have some reviews that are very interesting because they are full of pathophysiology of this axis, and in this one we can have a clear insight regarding epidemiology of simultaneous renal and brain damage. What we find is that this is around 20%, and this is similar in the different ways of having brain dysfunction. That is traumatic brain injury. You can see around between 10 and 26%, acute stroke, subarachnoid hemorrhage, intracranial hemorrhage, and in all of these cases, especially if you use the standardized KDIGO classification, you find that these patients between 10 and 20%, which is astonishing to me because if you don't look at the numbers, you don't realize it, do have also AKI. The axis works like this. From the kidney to the brain, we have a sort of change in the blood and plasmatic environment with the involvement of a lot of inflammatory mediators and opening of aquaporins and the release of mediators that tend to increase the severity of brain edema in AKI patients. On the other side, when you have primarily brain damage, you may end up having, through the stimulation of the sympathetic axis of heart and having a secondary renal damage. Let's take a closer look to the nephroencephalic syndrome. We know that chronic kidney disease do have similar kidney and brain risk in terms of damage, and this is similar in the AKI patients where, as I told you, there is this cytokine-induced damage due to oxidative stress and extravasating leukocytes that tend to go into the brain. On the other side, we have this sympathoadrenergic drive and renin-angiotensin-aldosterone system activation that tend to decrease glomerular filtration rate when the brain is primarily injured. This is typical, for example, in traumatic brain injury patients. We do have to take into consideration also some cases of augmented renal clearances in this patient, and this is very important because all the drugs that we give to these patients in order to to manage the brain injury might have lower plasmatic levels, and so we have to take in consideration the opposite thing, so the augmented renal clearance. There are other mechanisms that put the brain and the kidney in communication, and for sure many patients with brain injury, especially with trauma, may have sepsis and critical illness during their clinical course, and secondary kidney involvement. The same for trauma-related inflammation. Many of these patients undergo the administration of contrast media. We don't know how controversial is this topic, but if you have already some kidney involvement, the contrast media might be in cause for kidney injury, and the hyperosmolar drugs, which I will be talking in a minute. So we have this table where we can realize that in different types of brain damage, we can have different type of kidney involvement. In all cases, we generally tend to have sepsis-associated AKI risk. But, for example, as I told you, in TBI, the sympathetic hyperstimulation is typical, whereas in the other syndromes, osmotic nephrosis is one of the main causes. How to manage the brain-injured patients in terms of renal protection? Because we have two different hemodynamic patterns. We can have a decrease in mean arterial pressure due to traumatized patients or due to vasodilation in patients with acute brain injury. And in this case, we have to pay attention, obviously, to fluid balance, but probably norepinephrine is the first-line treatment in order to maintain mean arterial pressure and to, in some way, protect renal perfusion. On the other side, we might have hypertensive crisis due to cerebral edema. And in this case, we have seen that we have to reduce mean arterial pressure down to specific levels in order, again, to protect the kidneys. We have some post-hoc analysis of previous studies specifically focusing on the brain that try to see what happens to the kidney. And in this ATTACK-2 trial, they showed that the nicardipine levels, dosages were associated with AKI risk. That means that we have to pay attention to the level of decreased pressure in these patients. There is not much about fluid balance in these patients, but clearly it's a risk, because when we have a patient with a brain injury, with AKI and dysregulated management of volume in this patient, this might be something that triggers further evolution of both diseases. The only thing with that we know is that some authors have found an increased utilization of RRT in patients with fluid overload, and something on outcomes should be researched further. What about hyperosmolar solution, which are the mainstay, of treatment of acute brain injury? We know that increased sodium chloride load activates tubuloglomerular feedback, and this ultimately ends up with reduction in glomerular filtration rate. Is this something functional? Is this something organic in our kidneys? We know from this, today we could say, old study, that when in critically ill patient, you change the strategy from chloride liberal to chloride-free strategy in fluids, you improve the incidence of acute kidney injury. We know that balanced crystalloids do not have macroscopic impact on outcomes of critically ill patients, but we know that from the Bayesian standpoint, there is a high probability of improving mortality. For sure, we know that saline is fundamental when we have a traumatic brain injury patient. And in that case, saline utilization improves mortality of these patients. We know from physiology in experimental models and in human models that sodium chloride decreases renal blood flow. So we have to admit that these type of drugs do have an impact in renal function. So what do we know from current literature about the application of hyperosmolar solution in acute brain injury patients and their effect on AKI? In this case, this study was particularly interesting because in this population, they enrolled only patients who received a specific amount of hyperosmolar solution that was 30 milliliters per kilogram, so a high volume of hyperosmolar. And they excluded patients who stayed for less than a specific time. So these are high-risk patients. What they found was that, yes, AKI was associated with the sodium levels, with chloride levels, and especially they found that the chloride load over 2,000 milliequivalent of chloride over 7 days was associated with acute kidney injury in these patients. So this study was a prospective study who tried to compare a chloride-rich with a chloride-poor solution for hyperosmolar therapy, which is sodium chloride 23% versus sodium chloride sodium acetate. What they found was interesting because both solutions have a similar effect on intracranial pressure. They have similar effect on sodium and chloride levels in patients' bloods, but the chloride load was lower in the sodium acetate solution. So with the similar effect on intracranial pressure, they were able to deliver less chloride to this patient. What are the effects on AKI? Well, this is significant because KDIGO 1 and 2 stages were significantly lower in the acetate solution. So these authors can conclude that in their trial, this solution might be one of the answers to this kind of issues. A different outcome was shown by these patients that these authors who enrolled patients with 20% sodium chloride solution, but this was infused continuously with a specific protocol and target. And what they found was that, yes, this solution did increase significantly chloride levels in patients' blood, but at the end, the AKI incidence in the two populations was very similar. And so the message here, it could be that when you use this solution in continuous infusion, probably the effect on the kidney might be lower. What about children, which is my specific topic? Children do have hyperchloremia issues in the kidneys, and this study was specifically conducted in patients with acute brain injury. And again, they found that hyperosmolar solution increased chloride, and the AKI is associated with increased chloride. When you go, though, and look more closer to the data, you see that the non-hyperchloremia patients were essentially those who didn't receive or received very low levels of hyperosmotic solutions. So in the multivariable analysis, chloride was not anymore associated to AKI in this patient. So the signal here is lower. To me, probably this may derive from the fact that children do not have comorbidities and do not have associated damages, and the susceptibility in their kidneys is much lower. So probably hyperosmolar solution in these patients do have a lower effect. Mannitol has an impact on AKI, and today it should not be preferred, however, to sodium chloride. Issues with RRT, very quickly, we know that we have issues with the dialysis disequilibrium syndrome, intradialytic impotension. We have to control very carefully net ultrafiltration. We know from studies specifically conducted in patients undergoing intermittent hemodialysis that they do have magnetic resonance lesions in the brain that are compatible with ischemia. So we have to treat these patients when RRT is indicated with continuous treatment. Citrate might be neuroprotective. I didn't know that. There is some evidence on this, and we have to be careful with phosphate because hypophosphatemia is toxic in the neurologic patients. The very last study, very interesting because this secondary analysis is so recent. This is the AKI 2 study. They take into consideration a patient with a RAS lower than 3. I remind you that the AKI 2 trial was timing of patient treated within 72 hours from the indicated criteria versus the more delayed patients. What they found, interestingly, was that the less delayed population had a better outcome in terms of improving their RAS level. In other words, if you are timely with RRT in these patients, you tend to awaken them more effectively. The discussion is very interesting because they propose a lot of pathophysiology speculations that essentially affect the renal encephalic axis that I showed you. So in conclusion, AKI in patients with acute brain injuries is frequent, around 20%, 10 to 20%. Patients with renal injury and disease are at higher risk of neurological damage, and patients with acute brain injury show several pathophysiologic mechanisms towards renal dysfunction. So the axis between the two organs is present and strong. Careful management of all concomitant factors is required, and when you take care of the brain, you have also to take care of the kidneys of these patients, so their management is very challenging. Hyperosmolar solutions are indeed essential, but they affect renal function, so we have to be aware of this. When RRT is needed, this must be continuous, gentle. Net ultrafiltration should be dosed carefully, and delaying RT timing above 96 hours may be very detrimental in comatose patients. Thank you very much.